There's lots of reasons why you end up having an inability to adequately move secretions. Part of it is obviously having the artificial airway in place. The normal cough mechanism is impaired. The need to have suctioning available and it not being available could be another process. Inadequate humidification we've talked about. High oxygen concentrations have a tendency to reduce the mucociliary elevator's efficiency. Certain drugs fall into that category also. And just the fact that you have underlying pulmonary disease that perhaps either has an increase in secretion production or a decrease in secretion clearance, or both, can lead to problems where you end up having impaired clearance. And this is just showing that it's a cyclical process, that worsening of a disease causes more secretions to be retained. More secretions having retained lead to more complications and worsening of the disease, and just keeps on going. So what we want to try to do is mobilize and remove those secretions, thereby improving gas exchange, improving oxygenation, CO2 elimination, and hopefully reducing the work of breathing in the process. Generally, the rule of thumb is if somebody is producing 20 to 30 milliliters per day, that's a significant amount of volume of secretions. Patients with ineffective cough, patients with labored breathing, patients with abnormal breath sounds, and all the clinical signs and symptoms that you would end up anticipating if there was some respiratory distress present. So what we want to do is increase hydration, primarily through oral intake, and if necessary, IV fluids. There's also the idea that we can facilitate some humidity and some air, some hydration by using bland aerosol. We've talked about using sterile water. As far as a large volume jet nebulizer, being applying some degree of humidity to the airway, with the idea of if we can perhaps replenish some of the humidity that is not present, creating a humidity deficit. Can also use some hypertonic saline. We typically only use this with an ultrasonic nebulizer for sputum induction. We don't use it for routine therapy involved. The bland aerosol therapy is primarily used again for either correcting a humidity deficit, which is present with the dry therapeutic gases, upper airway edema, and as we mentioned with hypertonic saline, we can end up using a sputum induction. We want particle sizes that are in the normal, hitting the upper airways, so somewhere between 1 and 5 microns. We typically, again, use hypertonic saline as the mechanism because that will cause the fluid to move out of the intracellular, the respiratory mucosa into the airway, and therefore hopefully hydrating sufficient enough to create sputum. Downside to it is that it can be irritating in patients who are prone to bronchospasm. You can end up having a problem. And the same is true as far as just having, if my goal is to create secretions and so they can be expectorated, problem lies is if the patient can't do that. They can do the first part. In other words, we can make more secretions, but if they can't clear them, we got an issue there because now I'm just making matters worse in the process. So again, we talked about the lower airways, either using a small volume or a jet nebulizer, which is typically what we end up using, that 2 to 5 range. Ultrasonic, maybe even get into a smaller particle size, so we may actually be able to reach a deeper part of the lung. Talked about all this and there we haven't said. And again, just got to make sure that what we're mobilizing is not something where the patient is infectious, and if so, we need to take some precautions. We usually do a sputum induction before meals, We have the patient rinse their mouth and clear any excess secretions that may be in their mouth and nose. We're going to monitor them while we deliver the hypertonic saline for any bronchospastic changes that you may encounter. And then we usually try to obtain a specimen then directly after the administration of the hypertonic saline. And again, you want to handle that with special precautions as you transport it to the lab. And Chapter 15 in Butler has a process for that, but we're not going to use that as any kind of a performance evaluation. Just know about the ultrasonic. Again, you have a piezoelectric crystal that is creating sound waves, which is causing the hypertonic saline to be made into very, very small particles, which are then inhaled. We've talked about that before, so I'm not going to beleaguer that. Recognize that particle size is determined by the frequency, which is preset. The amount of mist or the volume of fluid that is being nebulized is controlled by the amplitude. And you'll never have to do this. I don't know why I even have it there. And then, again, the flow, there's a blower that's typically there to transport the nebulized hypertonic saline.
The frequency can't be changed?
Frequency is preset, yeah. We've already gone through all this aspect of it, so I'm not going to spend any more time. Other things we can do, and I think Lori may have talked about the fact of using things like acetylcysteine or Dornase alpha as mucus thinning agents, something to make the mucus less viscid and therefore easier to expectorate. Talk a little bit about coughing. The directed cough, you want to have the patient sitting as high as they possibly can. If they are unable to sit and they have to have them lie on one of their sides with the knees bent in this fashion, so they can take a deep breath and utilize it as best as possible. Under normal cough, you have the patient take a deep breath in, slightly hold while they build up pressure in the thorax, and they're going to forcefully exhale into whatever tissue or specimen container, which we're going to dispose of appropriate. These are the 4 phases to a cough. I'll start by that. There's some irritation that occurs that stimulates the cough centers. The patient then takes a large breath in. They contract the abdominal muscles while the glottis is maintained closed. So there's a buildup of pressure, a compression within, and then the expulsion that ends up happening as you release that. You open that glottis and you allow the gas flow to come out. And yeah, it can be at a very, very high speed, which means if you're in any proximity to it, you potentially could be the person receiving the secretions. And when Lori talks about doing tracheostomy care and cleaning and suctioning a trach tube, one thing you never want to do is look the patient directly on face to face, because bad things can happen. And then taking different ways to describe how that cough is when we do our documentation. Is it a forceful cough? Is it a weak cough? Was there a large volume of secretions that were created, or were there scant amounts? What color were the secretion? What consistency was it? Was there any presence of blood or blood streaking? And if there's any odor to the secretions, that can also be noted. You will encounter the organism Pseudomonas at some point during your career, and you will know Pseudomonas just by its smell, because it's got a very characteristic smell. Another type of directed cough is one that we're using a splinting technique. This is for patients that have an incision that it might be painful for them. And we're going to use a pillow or some other structure to be able to hold that area so there's not a lot of movement of the incision or possibly evisceration where the stitches actually are torn. We're going to apply some gentle pressure and while after they take a deep inspiration, we apply some pressure over the site and they exhale in that fashion. So here we're doing some splinting with the hands, but more ideally have a pillow. In fact, some of the open heart units will actually have specialized pillows that the patient takes home so that they can cough. I've seen special teddy bears and everything to be able to have that splinting accomplished. Another type of cough is what is known as a staccato or serial cough. This is one where the patient takes a moderate deep breath, performs a short breath hold, and then does 2 or 3 short coughs in that fashion, and they can then repeat it. It's called a staccato or serial cough. We've talked a little bit about the huff cough, but again, it's a moderately deep breath, short breath hold, and the patient does a cough where they do not have a closed glottis. It's an open glottis in that fashion. They should simulate a huff or a ha on exhalation. Similar is what's known as a forced expiratory technique. Some people consider them exactly the same. The difference in a way is the duration of the exhalation, where the huff is one blast out. The forced expiratory technique technically has a little bit more of an emptying that occurs. For our purposes, we'll consider them one and the same because most authors do. Okay, how about a chicken cough or a chicken breath? This is where they're doing the same kind of a thing, taking a breath in, holding it, and then during the actual cough, you have the patient do adduction of the upper arms, literally like they're a chicken wings. And if you want to put the chicken song dance on, you know, do that also. And this, in theory, has some self-compression of the chest wall, so that you're actually helping to mobilize secretions. Okay. One technique that we do use for patients who have paralysis is what is known as a quad cough or an assisted cough. And this is again where they take a breath in, have them do a breath hold, and we're going to apply some pressure to the epigastric area and basically force the diaphragm up in the hopes of generating enough to be able to push the secretions along. So along the epigastric area or the lateral thoracic cage, as the patient makes their cough effort, again trying to avoid the xiphoid region, which is potential for a breaking of the xiphoid process. Obviously, we're not going to perform this right after eating because that would be only prone to have them vomit. And we can do this whether or not they have an artificial airway in or not. And if you're using it, you can actually help the deep breath by using a resuscitation bag to be able to push on them. So here what they're doing is after the patient has a deep breath in, we're pushing down on the abdomen or on the lateral chest in the process. And there you can see using a resuscitation bag for a patient with a tracheostomy. I don't know why that's along two lines there. And the patient then can attempt to cough in that fashion. Another device which is used is this blue device that is up here in the front of the room. It's called the mechanical insufflation exsufflation. And we use this a lot with patients who have chronic neuromuscular disorders. So one of the things you'll see at camp is a lot of kids have what is called SMA, spinal muscle atrophy, where their spinal muscles just don't develop or are not strong enough to maintain an erect spine, or they can't stand. So they're wheelchair bound, but at the same time their spine is compressed and their thoracic cage then is malformed. So they'll use the manual insufflation exsufflation to inflate their lungs and then actually create a vacuum and try to remove secretions or promote cough that they can't get a strong enough cough on their own. And again, these are just some of the pictures of older devices, but that's one there. So what we do is we set a positive pressure somewhere around 30 to 50 centimeters, which is going to be applied over 1 to 3 seconds. And they can use a mask or hook it directly to the airway. That airway pressure is abruptly reversed to a negative minus 30 to minus 50 for a couple of seconds. And then we end up doing, if need be, you can do some of the quad cough mechanisms there. But you get a better flow with that mechanism than you do with the patient's able to do on their own. Interestingly, when we're creating negative pressure, you would think that would promote airway collapse, but it does not seem to happen. We do about five cycles of this inflation, deflation, and then we go ahead and have the patient try to cough, or we assist their cough. And that's a picture of what the device is. So we can do this automatically or manually. But again, it's a positive pressure, goes up to 60, but we don't normally go that high, 30 to 50 centimeters of water. And then a rapid switch to the negative side, and then allowing the patient to cough. We normally it's only about 5 or 6 minutes that we do this for, but somebody who is has some secretions that they just can't get out, we can do it for a longer period of time. And then we can also look at it doing something to make sure if the secretions are thick, looking at some mechanism of hydration. Questions on cough? If they can't do it, we can do it for them, is the bottom line. Let's talk a little bit about breathing exercises. First of all, just the pursed lip breathing. This is something that actually many COPD patients develop without our instruction, just kind of a natural mechanism where they want to promote a longer expiratory phase because of the airflow limitation they have, and they basically it improves the emptying of the lungs. We're going to have the patient breathe in normally through their nose to humidify, and then have the patient exhale slowly through pursed lips, again to attain an IE ratio of 1 to 3 or longer. Okay. So here's the patient exhaling through pursed lips, like they're pursing somebody. Diaphragmatic breathing, we've talked a little bit about, but I have a patient when they're lying in bed, lying flat, or as flat as they can get, putting a hand on their epigastric area and have them sniff or pant to feel that diaphragmatic movement, and we encourage them to try and push their hand out so that during the inspiratory phase they're using their diaphragm as opposed to using their accessory muscles to take a breath in. And again, trying not to have their shoulders move or their upper chest, but rather have their abdomen be the focus on it. So we're going to have the patient exhale through pursed lips, and you can use a book or some other thing other than their hand to focus them on it, and eventually getting it so that they're focusing on using their diaphragm when they're not only lying down but also sitting or even walking. And here's a diagram of somebody instructing somebody to use diaphragmatic breathing, or the patient doing it on their own there. And this is just with ambulation, having them again focus on breathing. We'll talk another time. I don't think I have anything here on it, but stairs are a real challenge for patients with chronic lung disease, simply because there's additional energy that has to be expended, not only to go forward but to go up at the same time. If you watch weightlifters or folks that do silly things like work out at the gym, When they're exercising or when they're when they're lifting a weight, they always do it during exhalation. They don't during inspiration, because the diaphragm is contracting and using energy at that point. You want to do it when the diaphragm is at rest. So what we'll encourage patients to do is to take a breath in, and then as they exhale, they're taking a step up. So they're not trying to take a breath in at the same time that they're taking a step. That's kind of what they're doing in conjunction with diaphragmatic breathing. Another technique is just relaxation exercises, using a little bit of yoga or a little bit of meditation, having them breathe out, in and out through their, breathe in through their nose and out through pursed lips, while they relax all the body, all the muscles in their body, from the top of their head down to their feet, or from their feet down up to their head, whichever direction you want to end up going. All right, next two are kind of different but kind of similar, so you'll need to make sure that you follow the directions, because they might make a test question, just saying. First one is called active cycle breathing. And we use this in conjunction often with the postural drainage position. So while they're in that position to drain a specific area of the lung, we're going to go ahead and do this active cycle, which is two different phases. First of all, you want to have them relax their upper shoulders and chest, do some diaphragmatic breathing at normal tidal volumes. Then we're going to have them do a deep breath, take a deep inhalation with a relaxed exhalation. This is there to try and loosen secretions and improve distribution of gas. Then we're going to follow it eventually by a forced expiratory technique, or a huff cough, to move those secretions towards the central airway and out of the airways entirely. So here's your sequence again: relaxation and diaphragmatic breathing at normal tidal volumes. Then we're going to do 3 to 4 deep breaths. And we're going to do some more tidal volume breathing, then some more deep breath, and we're going to do some more tidal breathing. So you can see we're alternating between just having normal tidal to having deep breath, normal tidal to have deep breath. The idea being is that with those deeper breaths, I'm actually on exhalation moving secretions closer to the central airway, after which we do a couple of forced expire techniques, and then we repeat it. Got the gist of that one? We're going to contrast that with what is known as autogenic drainage. And this is another technique that we teach. Again, CF patients are pretty good at picking this up. And here we're going to use diaphragmatic breathing, not just at 2 lung volumes, but a bunch of different lung volumes. And they're trying to remember to, we're teaching them to control their expiratory flows, so they don't have airway collapse. So we want to have the mucus moving but not creating a wheeze in the process. And the cough is suppressed until 3 breathing phases are completed. The 3 phases are what we call an unstick phase, where we're doing full breathing to FRC followed by breathing at low lung levels. The second phase is called the collect phase, where we're breathing at low to mid lung volumes. And the evacuation then is when we do an increasing lung volume followed by a forced expiratory technique. So this is the different phases. The unstick is the phase 1 there, where I have a deep breath in and then I'm breathing at just normal tidal, normal lower volumes, and then I'm gradually collecting, moving that secretions that have been unstuck towards the central airway. And then finally the evacuation phase, take deeper and deeper breaths, followed by a huff cough. And I'm going to videotape. So there's lots of different mechanisms we can use, and the benefit of these is the patient can do them independently with a brief instruction and demonstration back. But again, focusing on hydration, focusing on bland aerosol. If there's a need for pharmacologic agents, using those, and then the different cough types that you should be able to distinguish, and the breathing exercises. And I'll stop there. And it says, how many times have we just thought, I just close my eyes and the bitch will go away?